from University of Birmingham, who is a transplant cardiologist. We're going to hear about inotropic support in acute heart failure.
Thank you, Andy. So just moving from big data to, I guess, old-fashioned empirical observations and small patient numbers and clinical experience and anecdotes, I think that's quite a quick shift. I've divided my talk into two parts. The first part, I will focus on acute heart failure. I'll describe the different clinical phenotypes. And then the second part, I'll go into cardiogenic shock. I'll have a bit of discussion about inotropes and acute mechanical support in that section. So I'll start with the different clinical phenotypes of acute heart failure. We all agree that acute heart failure is not a single entity, it's not a homogeneous entity. It consists of a range of different clinical phenotypes. And we'll all be aware of patients who develop, for example, acute heart failure following an acute myocardial infarction. We will be aware of patients who have chronic heart failure who get admitted with fluid overload and congestion acutely. And then you have the occasional patient who comes in very hypertensive in acute pulmonary edema. So we recognize some of these different clinical phenotypes. And this is also acknowledged in the 2016 ESC guidelines. And they try to develop an algorithm to try and guide us in terms of in the management of these patients with acute heart failure. And within this treatment algorithm, there is a slight mention of this kind of different phenotypes. So you can see at the bottom of that flow chart, there is a mention of the vascular type, for example, and the cardiac type. The vascular type refers to what is generally believed to be a problem with fluid redistribution from peripheries into central circulation and pulmonary edema. And these are typically the hypertensive type, for example. But the gist here is that if you have a reasonable blood pressure, if your blood pressure is over 90, for example, systolic, then vasodilators is a reasonable option. You can see vasodilators dotted across various arrows and various paths down the algorithm. And it is summarized here as well that vasodilators, for example, can be trialed in patients without symptoms of hypotension with a systolic blood pressure of over 90. And I think this is where I would try and pick up on the acute heart failure phenotype a bit more, because I think what we're doing here is we're applying a single treatment to a very heterogeneous group of patients with acute heart failure. And I'll contend that what is more important is probably what the basic physiology is for some of these patients. So I think a description of the physiology of acute heart failure is actually quite important to understand a bit more about the effects of vasodilators, for example. And to go through some of the physiology, unfortunately, I will have to take you through some of the fundamental cardiovascular physiology in the form of a pressure volume loop. So this pressure volume loop is effectively the cardiac cycle drawn in a loop with a y-axis denoting the pressure and an x-axis in volume. So there's a vertical line going up, for example, in systole as the ventricle contracts. It generates pressure. Assuming competent valves, you have isovolumic contraction and pressure rise at that stage. And if it goes above the aortic pressure, your LV will start ejecting and it starts emptying itself. So it shifts leftwards down the volume axis. And towards the end of systole and ventricular relaxation, you have a drop in pressure, and it starts to drop the pressure in isovolumic phase again, assuming competent valves. And when the ventricular pressure drops below the left atrial pressure, then it starts filling, and it starts filling along the diastolic pressure-volume relationship. Now, a couple more things to add to this pressure-volume loop to make it a bit more interesting. So we mentioned briefly about the diastolic pressure-volume relationship, and this green line here is curvilinear. It's not a linear relationship, and it's shifted slightly upwards in patients with, broadly classed as diastolic heart failure with stiffness of the heart. And then you have the red line, which is a lumped parameter of afterload. It's generally called arterial elastance. It consists of various measures of afterload. And the steeper this line is, the higher your afterload becomes. And then you have the blue line, which is the end-systolic elastance, which is, crudely speaking, a measure of contractility, generally believed to be relatively load independent, so it's not affected, for example, by loading conditions. The width of the curve is the stroke volume, and you can see how the stroke volume will change depending on your contractility and your afterload, for example. And then there's one little arrow at the bottom here, which is the orange arrow, which is the what I call the limit of preload reserve, and this is a response to increase in loading, for example. What the ventricle does is try and recruit some of the preload to maintain stroke volume. So when you acutely load the left ventricle with increasing pressure, it dilates a little bit to try and recruit the preload to maintain stroke volume. But of course, this cannot increase infinitely, so it has to be a finite volume. And that is where the maximum recruitable preload is. And these are quite important, and I'll show you why. Now, some of you will look at this and say, well, this is all too complicated. Why don't you just give me ejection fraction? That's what we're all familiar with. And I'll show you that actually this is actually what ejection fraction actually is. So you can actually work out what ejection fraction stands for. And this is actually very, very simple, simple mathematical equations. So what we talk about simplistically as ejection fraction actually can be broken down in this pressure-volume relationship into a number of different things. So one of the key assumptions here is that we assume the V naught, which is the volume at zero pressure, is negligible. That's not always true, but for simplicity, I've made that assumption. But ejection fraction effectively becomes dependent on your contractility, your end-systolic elastance, inversely related to your afterload, which is your end-systolic pressure, and related to your diastolic volume. So that's what ejection fraction boils down to. So needless to say, I'm aware that Professor Cleland is here, but when there was a discussion about mid-range ejection fraction, I'm a little bit more kind of skeptical about that whole subdivision of ejection fraction measurements in the most recent guidelines. But coming back to the phenotype and the physiology of acute heart failure, and this is where it becomes important. So this is the pressure volume loop again, showing what we would consider to be the hypertensive acute pulmonary edema, for example. So on the blue dots there, you see number one there is a stiffening of the heart, so you have a slightly higher end diastolic pressure volume relationship, and with the increase in afterload, the left ventricle will increase the preload, recruit a bit of preload, and at the expense of increased filling pressure. So you go into pulmonary edema because you have a higher LVEDP. And you have a very high blood pressure because you have a significant increase in afterload, whatever the mechanism may be, whether it is sympathetic driven or whatever else. But this is matched by an increase in contractility and systolic elastance. So this is not a poor contractile left ventricle. This is a very well contracting ventricle, but it's acutely loaded against a background of some stiffening. So when you give somebody vasodilators, for example, in this case, what you'll see is this shift in the arterial elastance, the red line downwards. But because the blue line is so steep, you get a massive drop in pressure, but for a very small increase in stroke volume or a small reduction in the volume of the heart. So this is important because vasodilators in these kind of patients will achieve what you want to see, which is a drop in blood pressure and slight downward shift in the volume, and they start feeling a bit better. This is a slightly different kind of patient that also has some stiffening of the heart. And I would class these people as, I guess, more of a kind of HFpEF, if you like that kind of terminology. So you will notice that the ejection fraction is about the same. The ejection fraction is a stroke volume divided by your diastolic volume. So the diastolic volume is obviously the end of the edge of the box of the loop, and you can see the ejection fraction is about the same. So there is a slight increase in afterload in the arterial elastance, and it's matched by a slight increase in end-systolic elastance. But there's a marked increase in diastolic pressure relationship, so you have a stiffness problem, for lack of a better word, I guess. Now, when you give these people vasodilators to achieve a significant decongestion and reduction in filling pressures, these people will more than likely develop significant hypotension. So you can offload the heart, but at the cost of probably quite more hypotensive effects. And these are the patients that we see, I guess, quite commonly with chronic heart failure, your dilated cardiomyopathy. You can see there's nothing wrong with the stiffness of the heart. The problem here is that the loop is shifted very, very rightwards. So because it's a curvy linear relationship, the further right you go, the stiffer, in inverted commas, the heart becomes. Not the intrinsic properties of the heart itself, but it's just the fact that it's shifted quite far out, it's stretched out. So you can see the ejection fraction here is very low because the stroke volume is small, and you have a big diastolic volume. So this is your typical kind of heart failure with reduced ejection fraction patient. What is obvious here is that although your arterial elastance may not be terribly high, but you have a very, very blunted end-systolic elastance, the blue line. So what you have is a typical kind of ventricular arterial uncoupling. So you have a heart that is very sensitive to afterload. So this is a case of afterload mismatch. And this heart would have recruited all the preload that it could, because that's why it's so dilated. And when you give somebody like this with a vasodilator, for example, because the blue line is relatively flat, you get a very slight drop in blood pressure, but a large increase in stroke volume and offloading of the heart. So these patients do very well with vasodilators in terms of their acute hemodynamics. What we're talking about here is acute hemodynamics, not how they do in a year's time. And these are not new concepts. So, for example, there's a study that looked at the effects of SNP, so sodium nitroprusside, in patients with heart failure and reduced ejection fraction versus heart failure with preserved ejection fraction. And you see the significant blood pressure drop in the HFpEF patients with relatively small increase in stroke volume relative to the HFrEF population. And in fact, if you go back even further, there was a lot of studies that have demonstrated the acute hemodynamic benefit of sodium nitroprusside. I'm sure a lot of us don't really turn to sodium nitroprusside anymore, but I still use that sometimes. But these studies they go back 20, 30 years, and they have demonstrated consistently in patients with heart failure and reduced ejection fraction. It lowers your wedge pressure, but at the same time, it also increases your stroke volume. And the reduction in LV volume also reduces functional mitral regurgitation. So functional mitral regurgitation is a consequence of remodeling of the heart, dilatation and remodeling of the heart. And as the volume shrinks down, your regurgitant orifice area will reduce, and you reduce the severity of the mitral regurgitation. And a group from Cleveland Clinic even suggested a prognostic benefit, so they showed an improved outcome. This is based on a single center observational study with nitroprusside in acute heart failure. But this is all about the left ventricle, but I don't think we should just focus on the left ventricle, and this is a discussion about the physiological phenotype. And I think we also have to bear in mind the importance of the pulmonary circulation. I think that's often underestimated as well. We know that systemic vasodilators are bad if you have significant pulmonary vascular disease or pharmacologically fixed pulmonary hypertension. The problem here is that you will reduce your systemic vascular resistance, you drop your systemic blood pressure, but you have minimal impact on your pulmonary circulation, so you have a significant hypotensive response, and patients can die from systemic vasodilatation if you have fixed pulmonary hypertension. And we actually looked at that ourselves here. This is with SNP, so we did use SNP. And these are patients with a combination of various forms of pulmonary hypertension. So this is, if you look at patients with mixed pulmonary hypertension, for example, now defined as pre- and post-capillary pulmonary hypertension. Those patients in blue dots, for example, has high diastolic pressure gradient, high pulmonary vascular resistance. They have a very little drop in their PVR and no significant increase in the pulmonary capacitance. So these people tend to develop significant hypotensive response to SNP. Those in green, for example, they have lower diastolic pressure gradient, and they respond very well to SNP with significant increase in cardiac output. And interestingly, not significant drop in blood pressure, because the increase in cardiac output counteracts the vasodilatory effects. So wrapping up the first part of the talk, I would say vasodilators, I think is effective in unloading the left ventricle, but I think the effects are quite dependent on the physiology of the heart and the circulation. I would suggest that we look beyond the ejection fraction measurement and look at things like LV volume, for example, look at the blood pressure, for example, which is what was recommended by the ESC, and also the right ventricle and pulmonary circulation. So I think for acute heart failure, this is something that we should start looking a bit more on the structure of the left ventricle and the pulmonary circulation a bit more. And interestingly, going through a lot of the acute heart failure trials and vasodilator trials, for example, you will struggle to find a single trial, correct me if I'm wrong, but you struggle to find a trial that describes left ventricular volume. A lot of these trials will tell you what the ejection fraction is, but none of these trials will tell you what the left ventricular volume is. And I think that is a problem. So applying the same principle, trying to phenotype the cardiogenic shock, and try and use the phenotype to describe management of cardiogenic shock. Now, we know that cardiogenic shock also isn't a homogeneous condition. We all like to think that it's one condition, but it isn't. Cardiogenic shock has a number of different causes. Obviously, we are aware of the patients with acute myocardial infarction developing cardiogenic shock as a result. But we, in the transplant centers, deal with a lot of patients with end-stage heart failure. Of course, pump failure is a cause of death in heart failure. So we see a lot of these people who get into the stage of cardiogenic shock as a result of end-stage cardiomyopathy. So if we look at the ESC guidelines, last year's guidelines, for example, cardiogenic shock was defined as hypotension with evidence of hypoperfusion and in the presence of adequate filling status. And then if you look at the recommendation for treatment, and I'll go through some of these individually, the first thing that they mention here that has got a class 1 recommendation is fluid challenge, at least 200 mils of fluid over a short period of time. And I take a slight issue with that because one of the key definition here is adequate filling status. So we're not doing this because we're not giving fluid because we think the patient hasn't got adequate filling status. If we think he has got cardiogenic shock, then by definition, the patient has adequate filling. Are we trying to then achieve supranormal filling status? There's certainly no evidence for that. But more importantly, I think if you look at the shock trial, for example, most of these patients have a wedge pressure of 25, for example, and right atrial pressure of 15 here. So these are not patients who are inadequately filled. And we have our own data, for example, looking at the wedge pressure and trying to define the phenotype of these patients with cardiogenic shock. And we look at patients with end-stage heart failure compared to acute myocardial infarction. And you can see the patient with end-stage heart failure has even higher wedge pressure, almost 30, and high right atrial pressure of almost 20. I wouldn't dream of giving fluids to these patients. And you might say, okay, maybe that's not so bad. Maybe you can try in patients with acute myocardial infarction because the right atrial pressure is only about 9. But using the single beat method described by Klotz, we also worked out for example, diastolic pressure relationship in these patients with acute myocardial infarction. And it's consistent with what people have published in the past, showing significant stiffening of the left ventricle in the context of acute myocardial infarction. So although their left ventricular filling pressures is slightly lower than end-stage heart failure, their heart is much stiffer, which will mean a significant rise in filling pressures in response to a same unit change in volume. So I would personally be very cautious about giving fluids in cardiogenic shock. The second thing is about inotropes. And inotropes, I guess, is what we would turn to quite often in the setting of acute myocardial infarction or cardiogenic shock, for example. And in the same way, we try to document some of the differences or some of the similarities between patients with end-stage heart failure and acute myocardial infarction. And you'll see that patients with end-stage heart failure, unsurprisingly, have much bigger cardiac volumes because they've progressed and these are the patients who have dilated over the years. The ejection fraction tends to be lower, and that's also, I guess, fairly intuitive. But what this means is that these people are shifted far further to the right, as we described before, and their end systolic elastance is much lower, and they are much more sensitive to afterload because the ratio of your arterial elastance to your end systolic elastance is much higher. So I'll summarize this in this cartoon here. So bear with me. So first thing here is that you have bigger volume in your end-stage heart failure compared to your acute myocardial infarction. These are remodeled hearts. They're dilated. The stroke volume, the width of those loops are not different. So the stroke volume is the same. But because their volumes are so much bigger, the ejection fraction is much lower. Yeah. So the cardiac output, in that sense, isn't different because stroke volume is not different between the two groups of patients. But the patients with acute myocardial infarction have a stiffening of the heart, so you can see an upward shift in the diastolic pressure and volume relationship. So even for a small volume heart, their wedge pressure is higher. Their left ventricular and diastolic pressure is higher. The arterial elastance isn't that different, so there's no significant difference between two groups of patients, whether they are acute myocardial infarction or end-stage heart failure. The afterload is the same. But the problem here is that in the end-stage heart failure, their contractility is much worse than acute myocardial infarction. So the ratio of the two is much worse in end-stage heart failure. What that means is that it's much more sensitive to afterload and much more sensitive to vasodilatation as well. And this is just an illustration of the response to different inotropes. If the inotropes that you use has got some vasodilatory effects, you might lower your arterial elastance a little bit with an increase in the blue line, the steepness of the blue line, which is your contractility. Now you assume that there is some contractile reserve left in the heart, but if you have a heart that is end stage and cannot demonstrate any increase in stroke volume because there's no contractile function left, then you will not see this steep rise in the steepness of this blue line here, the end-systolic elastance relationship here. And what you end up doing is that you end up vasodilating the heart without an increase in contractile function. And that's something that to be aware of. And then we come to vasopressors. Now, vasopressors, to me, it's alarm bells. So vasopressors are not a good thing to use in end-stage heart failure. And we talked about the ventricular arterial coupling and the afterload mismatch, for example, in end-stage heart failure. So if you have a fixed blue line here at the end-systolic elastance, and you just give vasopressors to vasoconstrict and increase the afterload, steepening the red line, what you'll see is a narrowing and narrowing of the loop, because you have reached the limit of recruitable preload. So your heart cannot recruit additional preload to maintain your stroke volume. So you might get pressure, so you can see where the two lines cross. The end-systolic pressure may be higher, but you're sacrificing your flow. So one of the key things that we talk about in advanced heart failure often is pressure and flow. So if your target is just to increase pressure, vasopressors is fine, but you will compromise blood flow to your organs. So pressure is not the same as cardiac output, and it's not the same as flow. So to me, if you start having to use vasopressors in acute heart failure, that is a bad sign. So we come to the last bit, which is acute mechanical circulatory support. So very briefly, I've kind of divided this into surgical approach and percutaneous approach. So in Birmingham, I work very closely with the surgeons. I share office with 4 of them, so I've got enough grief on a daily basis. So we talk to each other all the time about patients with cardiogenic shock. So I'm involved in some of the insertions of some of these percutaneous devices. So for example, I put Impellas in, I put ECMOs in, and percutaneous RVADs. We don't use tandem heart because it's just too complicated. And my surgical colleagues will help out as well in some ECMO cases and with the surgical implants of left ventricular or right ventricular or biventricular support. So the Impella is a small catheter-mounted pump. It's based on the kind of Archimedes screw. It spins 20 to 30,000 RPMs. It's got a pigtail that sits in the left ventricle. It sucks the blood from the left ventricle and delivers it to the outlet area that sits in the aorta. That bend that sits across the aortic valve. So you're taking the blood from the left ventricle, delivering it into the aorta. The Impella CP is what we use now. We've moved away from Impella 2.5 because we don't think 2.5 is quite enough. CP provides you probably about 3 to 3.5 liters, generally speaking. There's also Impella 5.0 that we have used sometimes with the auxiliary access, but usually we go from the femoral access. It's 14 French, and it's 14 French. The sheath is 14 French. The catheter itself is actually quite small, and you get it in, and then you peel the sheath away, a bit like pacemaker sheaths, and then there is a separate sheath that, I guess, tamponades the puncture point, the 14 French hole that you have made. It works very well. It does unload the left ventricle. It works very well particularly in the context of acute myocardial infarction. Not so well in the end-stage heart failure patients, and I'll show you a bit more of that. In terms of ECMO, this is the peripheral ECMO, but you can cannulate the heart centrally using sternotomy, for example. So peripheral ECMO, we have a venous and an arterial cannulation. The venous line is usually positioned around the right atrium, preferably up to the SVC, but sometimes it can be quite difficult because we don't always do it in the cath lab. Sometimes we do it in fact, more often than not, we do it in ITU with TOE guidance, which is it can be a bit hairy sometimes. And it's usually about 23 to 25 French venous cannulation. For the arterial cannula, we normally go 17 to 19 French, depending on the size of the patient. We always put a distal perfusion cannula to avoid ischemia of the leg because the tube is quite big, and often you can get ischemic problems in the leg. There is about a 3% amputation rate with ECMO, so there is significant morbidity with ECMO. And anybody contemplating ECMO, I think my advice is always get distal perfusion cannula access first, because once you get a big pipe in, you struggle to get a distal perfusion cannula down. So what the ECMO does is that it creates a very non-physiological circulation. You have a completely parallel circulation, taking blood from the right atrium or the venous system through an artificial lung oxygenator and putting it back into the femoral artery. So you have blood that's going back retrogradely to the left ventricle. This will increase the outflow of the left ventricle. It will empty the right ventricle. So it creates a very abnormal pattern of blood flow, really. It's connected up to a centrifugal pump. This is the pump that we use, Centrimac Levitronics. So it's driven, it spins round and round, and it's driven by that cube there, which is a magnet, and it's programmed by this console here. You can adjust the pump flow, for example. The problem with the ECMO is because you have retrograde blood flow going back to the failing left ventricle. Often you get LV distension. Your LV is not able to generate forward flow. You get distension and pulmonary edema. So you can get pulmonary edema with ECMO, but you have completely normal blood gases because the ECMO is taking care of the blood gases. So we will have a low threshold to unload the left ventricle, and what we would normally do is put an Impella in on the other side of the groin to unload the left ventricle. So here you can see the venous cannula sitting in the right atrium and the Impella sitting in the left ventricle to unload that. And physiologically, that's what we're trying to achieve here. We're trying to move that away from the increased distension of the left ventricle, increasing volumes, into a smaller volume left ventricle. And you develop this triangular shaped pressure volume loop because you lose your isovolumic phases. The Impella pump runs continuously, so it continuously empties the heart, so you lose that straight box-like pressure volume loop. We also put in right ventricular support. So this is a Protect dual cannula that we have used, and this is our kind of standard percutaneous RV support. We have used this in post-transplant patients. We have used this as biventricular support with Impella, for example, and we also use this after a bad implant to rescue RV failure. It can be connected up to an oxygenator to convert it into what is effectively a veno-venous ECMO. So this is an example of a big Protect dual cannula inserted in the right jugular. It's 29 French, parked into the pulmonary artery, and it works very well. In this case, we used it for a biventricular support for this patient who had severe end-stage heart failure and cardiogenic shock. You can see here previous stenotomy, so the surgeon said if you can get away without opening his chest, that would be preferable. So we went with percutaneous approach, and with the Impella itself, we didn't quite provide enough flow, so we converted that into a part of the ECMO circuit. So we took that as a venous drainage, cannulated the femoral artery, converted to a VA ECMO plus Impella, and then he was bridged successfully to a long-term left ventricular assist device implanted by thoracotomy. I'm not going to go into much detail about long-term or durable VADs because I know Dr. Dar is going to cover that in a bit more detail. But effectively, they do the same thing as the Impella, or the Impella does the same thing as a durable VAD, depending on how you look at it. It does unload the left ventricle, changing the shape of the pressure volume loop. In terms of temporary surgical support, we can support the heart biventrically using surgical cannulation of the heart. So usually in the right atrium to the pulmonary artery, and left ventricle or left atrium, or even left pulmonary vein to the aorta, for example. Here, this is a case report that one of my fellows wrote up with successful bridging to transplant with a patient with AL amyloid. She's now 2 years out from a transplant. So this is all a bit, I appreciate it's all a bit complicated, and so I'll just kind of leave you with some of these questions and I guess my approach, or our approach in Birmingham. So I'll leave you with this kind of quick summary of our kind of flow diagram. So I think the first thing I'd say about cardiogenic shock is that we have to be able to recognize it. I think we have a very low threshold, for example, to check for acid base, for example, all of these things. I think the first thing to do is recognizing it in the first place. More often than not, cardiogenic shock, particularly in the end-stage heart failure, isn't picked up early enough, and these people are very, very sick. And then we have a fairly kind of ad hoc MDT discussion. As I said, I work very closely with the surgeons, and we go through the patient, and we often convene by the patient's bedside and talk about the various comorbidities and where we think the exit strategy is, for example. Exit strategy is very, very important. We will not support somebody who hasn't got a way out. So, and then if they are candidates for mechanical support, for example, we look at various things. For example, we look at the Intermex class, which describes how sick they are, how acute they are. Intermex 1 describes the patients who are what they call crash and burn. So usually these people have hours, you have to make a decision within hours. So these are very acute patients. So we tend to favor kind of ECMO in that kind of setting, really, if you have a very acute cardiogenic shock. And then the more stable you are, then we can start thinking about perhaps even a balloon pump or directly to a durable left ventricular assist device, for example. So this is a small series of that we have collected, for example, looking at percutaneous support. So this is Impella plus or minus ECMO. And end-stage heart failure is difficult to treat because you're committed to multiple bridges. These people don't recover. Some patients with acute myocardial infarction and cardiogenic shock can recover. So you're committed to multiple bridging and keep getting them to transplantation or to a left ventricular assist device is quite challenging with percutaneous support. And these are very, very sick patients. The average lactate level is about 10. So these are very, very sick patients. But we've moved towards a kind of earlier biventricular support with BiVAD, and we're now seeing probably about 60% survival up to about a year, successful bridging with earlier biventricular support. So, these are patients with lactate about 4 to 5. So early recognition is important, and early biventricular support for patients with end-stage heart failure is important. So I'll leave you with these few points about cardiogenic shock. I personally don't think it's a class 1 indication to give fluids. I think it could be potentially dangerous for some of these patients. I think inotropes can work in some patients, but there has to be a continuous monitoring of the response because, just because you give some debutiment doesn't mean that they will increase their cardiac output. Vasopressors for me is a big alarm bell. The moment you have to start vasopressors to get the blood pressure up, then to me that's a signal that they should be considered for mechanical support. And for acute mechanical support, I think most centers would advocate a kind of team-based approach. And I think we're looking at potentially getting cardiologists involved in delivering some of these acute support. And I think the nature of the support has to be dependent on the phenotype that we discussed. Thank you.
So thanks for sticking to time. Are there any questions from the floor before break? We do have time for 1 or 2 questions. Andrew?
Thank you very much for schooling me in particular volume. Fascinating. For those of us not in centres with your expertise, and there's a long travel time, potentially, so 3 or 4 hours post-infarct, we think a patient might be suitable, we're not sure. When do we ring? Who do we pick up the phone to? What tells us who should we not send, I suppose, but also how low should our threshold be?
I think the acute infarct patients are quite interesting because, and I'm sure OS will support that as well. It's quite a mixed bag of patients. You have patients who have very clearly developed significant pump failure. Those patients actually are relatively easy to manage. It might sound funny, but actually all you need to do is probably like a bit of like an Impella, something like that will be enough. But some of those patients develop a profound hypotension, and you look at the RV, it's completely empty, it's very, very vigorous. Those kind of patients are far sicker. They tend to be, I guess, a bit more inflammatory type of patients. Those patients often need biventricular support with ECMO potentially. So they are quite different. I think if you end up having to put in a balloon pump and some NORAD, for example, then to me that's probably the point where you have to start thinking about transferring the patient. And I think there are always concerns from intensivists about transferring very sick patients. And of course there are concerns, but there's no way around that. You just have to ship the patient across. I was in Paris for a short while, and I was lucky enough to go out with the surgeons to retrieve the patients. We just can't deliver that kind of service 24/7 the way they deliver it in Paris. They have 2 police outriders driving us out to district hospital outside Paris to retrieve the patient, where they cannulate the patient in CCU. There's not even a scrub nurse. The surgeon goes along with me. The two of us go along, and he just poured iodine all across the groin. We washed our hands by the basin, and then he just cracked on. 15 minutes later, the patient is ECMO. We just cannot deliver. I don't think we can afford that kind of system where we have our ITU full of patients like that, it's going to be a disaster for a lot of other clinical work. So I think there has to be some sort of recognition that some patients are beyond salvage, and some patients I think refer early. That might be.
But essentially the message is, if in doubt, ring.
Oh, absolutely. I think there are a few things that I think would be certainly of major concern. People who have multiple sternotomies in the past, they are extremely challenging to support. Trying to get them through. If they have comorbidities, diabetes with vascular disease, for example, they won't do well either. I think, there's some discussion about age and things. I hate to say this, but age does come into play. There's no doubt about that. It's very hard to bridge a 65-year-old from ECMO to VAD and all those kind of things. It's very, very hard. We've done it on a couple of occasions successfully, but we equally have patients who have died. So it's that's a very challenging group of patients, and those patients you have to be very selective. The patient that we bridged successfully he was walking up Snowdon the week before, so he was 67, and we managed to bridge him successfully, and he's still alive to transplant. But it's very difficult. Those are very challenging patients.
Thanks for your talk. Clearly quite challenging. Describing how you make decision about people with cardiogenic shock, but I wonder whether you could comment on co-management of device plus medical therapy, because what I sometimes encountered that you end up seeing these patients on ECMO plus inotrope, sometimes plus beta blockers, as well as renal replacement therapy and so on. So what basis do you evidence do you take for making decision whether this should be ECMO only or plus inotropes?
Yeah, so the inotropes it depends on the patient. So, for example, if the patient needs a bit of inotropy to maintain some left ventricular contraction to empty the left ventricle, that's one of the reasons for using some of the inotropes. I must say we've moved away from that because we have, so this is what we call venting the left ventricle in the face of significant afterload increase with ECMO. So we moved away from that because I don't think it works terribly well with inotropes. So this is why we kind of electively Impella patients. I think the risk of Impella is actually relatively low if you manage it. Our ITU nurses are fully trained up in that. The exercise problem isn't usually a huge problem. We always go with micropuncture, ultrasound-guided puncture, and those kind of things. So we would normally go with that just so that we can minimize the use of adrenaline and all those kind of things. And we go for a fairly modest blood pressure level because these people will have 4 or 5 liters of blood flow with ECMO, so they are not short blood flow. And we will normally go with a mean arterial pressure of 65, maybe even 60, depending on how old the patient is, for example. And we will have PA catheter. We'll measure the various metabolic parameters to make sure they're adequately perfused, for example. So I think those are the measurements that you have to take. So we don't put everybody on inotropes on ECMO. We use it to try and flog the heart to try and get the heart to work a bit more, but we moved away from that because it never works.
Right, well, thank you. I think we'll stop there for the break. And one keen voice.
Sorry, can I ask a lower level question? I was a bit blinded by your science, so you might have answered this. So can I ask you, when you do these interventions, what percentage of the people who have these interventions get a symptomatic benefit, then go on to have transplant and then lead a good quality of life? Yeah,
so this is why the exit strategy is very, very important. We have to be clear that it is possible to get people to a point where they can have a transplant or a durable left ventricular assist device before we even go there. So we don't put it in willy-nilly. And I think one of the things that we have seen as well is that the moment they develop complications, that is a huge setback to these patients. So one of the biggest predictors of mortality actually is complication on mechanical support. So with age and everything else aside, the moment they lose the leg or get vascular complication or any of those things, it's incredibly difficult to turn them around. So those are decisions that we have to make, and then we have to say, look, it looks like we will not be able to get this person through transplantation or to a left ventricular assist device, in which case then we'll have a discussion with the family, for example, about turning off the device, and the patient will die from that. But most of the patients that we've supported to a ventricular assist device, to a transplantation, they are no different from any other patient that we transplanted, for example. They don't come out with any kind of functional deficits in that sense. some of them will have some psychological, almost like a post-traumatic stress condition, and that's something that the ITU psychology team picks up on very, very quickly. And that's certainly one of the things that we have seen in these kind of survivors.
We're going to take one more quick question and then quick answer.
Just to answer the question that you asked, from the ELSO registry, which is the VA ECMO registry, the survival after you go on VA ECMO is around 40% to discharge. And if you take patients with acute myocarditis or with acute problems, then that increases survival to around 60%. So yes, it is a high-risk procedure. The patient's likely not to survive. The kind of patients that we generally try to take are the patients that you have an idea what the outcome is going to be at the end. So are they going to be transplantable? Are they going to be suitable on LVAD? And if they're not, then they're probably not suitable for ECMO, because to have a patient on ECMO and then have them awake in front of you and to tell them that you're going to die when you switch off the machine, and switching that machine off is incredibly difficult. So I think before you go in and put in the ECMO device, you really have to have a strategy to get out at the end. And I think what I'd encourage everybody is to speak to your cardiologist, as Andrew was saying, your transplant centre, and just have that conversation about where are you trying to go with this patient, and if they are potentially suitable for transplant, and the ECMO could reverse their renal failure, could reverse their liver failure, and allow them to become transplantable, and I think then you have a potential candidate, and those are the kind of patients I would consider for ECMO.
Thanks very much.